VP of Product Content here at VitalWare. So Jen, I'll hand it over to you.
All right, sounds good. Welcome everybody to the final rule. We are a bit later this year than what we tend to be because CMS was late in releasing everything. Luckily, I guess, they do seem to be getting this down. So there are some changes, but they're not as extensive as we've had in previous years. I do always want to throw up a bit of a disclaimer here that we're current as of this time, but we've already had changes that are going to affect the OPPS yesterday even because of the emergency use authorization for some of the COVID vaccines. So we will keep you updated in other ways by sending out vital alerts and updating our site and stuff. You know who I am. Let's just jump right into this. So I'm going to start with some of the boring stuff. I'm not going to go over this a ton, but just so that you are aware of what's happening to the big payment issues. So our conversion factor went up. That is the amount that we multiply by the relative weight in order to get our values. So we are up about $2 there, a little more than $2. They are still applying, no big surprise here, they are still going to apply the 2% reduction factor for hospitals that don't meet the quality reporting requirements. And so if you don't happen to meet those requirements, you're actually getting a conversion factor of $81 and about 18 cents there. No changes to the rural SOL community hospitals, no changes to the hold harmless provisions for the cancer hospitals. We continue to see some changes in the wage index adjustments. So I've heard they started this last year. They've actually done some more fairly major changes to that for this year. So if your wage index has changed, don't be too surprised. I did some quick stats on that. 10 hospitals have an increase in their wage index of more than 10%. We've got about 50 hospitals that have an increase between 5 and 10%. The bulk of the hospitals, 1,230, have a minor increase of a little more than 0 to 4.9%. 163 hospitals, no change. And then we have almost 1,500 hospitals that are having a decrease in their wage index up to 2%. And 463 hospitals that actually have a decrease of between 2 and 5%. So they did cap the wage index decreases. They didn't cap the increases. And basically what that is all about is to try and make it a little more fair so that the hospitals that are in more rural areas, smaller hospital markets, don't have such low wage indexes. Indices, I suppose is the right word. But that all has to be done in a budget neutral manner. So that means if some hospitals go up, some other hospitals have to go down. And that is the way that is. So that is all published. We have all of your wage index information in VitalWare. And that is all published out on the website under the CMS website if you need it there under the IPPS wage index stuff. Hospital outlier payments aren't changing a whole lot, except that our fixed dollar threshold is going up to $5,300 instead of $5,000. So what that means is that you're not going to qualify for an outlier payment unless your costs exceed a fixed dollar threshold of $5,300, as well as exceeding some APC calculations there. There's no change in the way we're going to calculate those outlier payments. It's still going to be 50% of the amount by which your costs exceed. Some complicated math there. So that's kind of the boring payment stuff, but just so that you can, like I said, have a basic grasp on what they're doing to actually change dollars. Not much we can do about it, but those are our changes. So I would like to just quickly, I do this almost every time, just go over a quick comprehensive APC refresher so that everybody knows what I'm talking about when I'm talking about the comprehensive APCs. These are services that typically have other services along with them that are packaged. So if you perform one of these comprehensive APCs, basically everything on the claim is packaged in with these exceptions. So per law, totally diagnostic services are excluded. Some things like ambulance are excluded. Some pass-through items are excluded. And this year they added as an exclusion COVID-19 treatments that are approved for the outpatient setting. Otherwise, your stuff is included in the comprehensive APC. So if you do diagnostic procedures, lab tests, other treatments that are done at the same time of service as these comprehensive, all of that stuff is packaged in. And of course, more and more of these things are being converted to comprehensive APCs. So kind of think of them as mini DRGs, mini outpatient DRGs is kind of the concept with those. So those are the J1 comprehensive APCs. They can qualify for a complexity adjustment, and that would happen if you do certain combinations of procedures together. So I just gave you one example out there just so you can understand a little bit better what I'm talking about there. So if you do a debridement of a bone by itself, that has an APC of $50.72 and it gets you about $1,400. If you do a debridement of a bone and a bone biopsy, they consider that to qualify for a complexity adjustment. And that actually bumps this all up to APC 5073, and it pays you about $2,370 instead of the $1,400. So that's kind of how those work. We also have a second category of the comprehensive APCs, and those would be the J2 services. And those are triggered when you do a specific combination of services. And when you do that, all of the other payable services on the claims, on the claim are bundled in together. So we have three categories of that. That would be the comprehensive observation services. It would also be an ancillary outpatient services if the patient dies prior to being admitted. And it's going to exclude the services that are assigned into a new technology APC. So that's good. At least not everything is packaged together, just most things. All right, so now let's just get into the specific changes. Basically what we did was add in 2 new comprehensive APCs, and they really just did this to make sure that they weren't violating 2 times rule, that they had a smoother flow through the services. So they added a level 8 urology and a level 5 neurostimulator. The gist of that is that the penile prosthesis and the urinary sphincter procedures are being reassigned to this higher one. And you would think that would be a good thing, but that's actually going to decrease the reimbursement just slightly. The neurostimulators, again, they've actually added a higher level, but right now there is nothing assigned into that highest level. And so we have a little bit of decrease as a result of this change currently. And I'm just going to take this opportunity to go back on my soapbox there. Just a quick reminder that they do all of this using your claims data. So it's very, very important that your charges relate to the costs of your doing business, that you're not assigning your charges, say, based just on APC weight and that sort of thing, because what that's going to do is eventually drag your averages down. You want to make sure that you are reporting to CMS your actual costs. All right, let's talk about some changes to the packaged items and services. They've already packaged tons and tons of stuff. There's not a lot more they can do with this. This is actually good news for us, I think. They've created a new category of lab tests that are going to be excluded from packaging. And this is going to apply to the multi-analyte analysis testing with algorithmic analysis. They have decided that these tests are typically not related to the OPPS encounter for care. And so they're going to pay for these separately. And you can see the codes there that this is actually applying to. So if you are ordering an assay of 12 different biomarkers in order to ascertain the probability of a patient having rheumatoid arthritis or ovarian cancer or any of these different things, they've decided that that usually is for future treatment planning, and it usually isn't related to the immediate encounter. And so instead of now being packaged, these are going to be separately paid. And you'll notice down here that this ruling is going to also apply to any future cancer-related protein-based MAAA tests that are being developed, because these codes change constantly. We're getting more and more genetic testing every day, it feels like. All right, moving along, we have a little bit of a change to unclassified blood products. These were previously, or I guess I should say they are this year currently packaged. These are now going to be assigned status indicator of R for next year. Notice it's real minimal payment right there. So they're intending to give you some reimbursement, but they also want to encourage any of these new blood products. They want to encourage the manufacturers to quickly seek out new HCPCS codes for their products so that they aren't assigned this minimal payment. So I always say it's very important that you give accurate cost information, but it's critical for these types of things, because when CMS takes a look at the charges for this, they're seeing that the charges for this are around $8. And so that's what they're paying you for that right now. I suspect that the reason that the charges are showing so low for this is because people are going off of the APC reimbursement for low levels, and as a result, we're not showing accurate cost data to CMS. All right, that is all of our changes to the packages. We're going to look at updates that are specific to APCs. And this is where stuff is going to get a little bit more interesting. We have some changes to new technology APC groups. Again, I'm not going to take a ton of time with this because this is more of interest to the larger hospitals that are actually doing the new technology stuff. But just so you can have a quick look, I put it in green if you're actually getting more money, and in red if your reimbursement has gone down. Unfortunately, we're all red this year, so you can kind of see what's happened. Take a look at this one. It's actually gone down by more than half. And again, that's based on that claims data. The folks that are doing that are reporting very low costs for that. So either that's true, or they're not exactly sure how to price it, and so they're pricing it low. All right, we have a new code this year of 92229. This is for the automatic intelligence algorithm that analyzes images of the eye. So it takes pictures of the retina and then it spits out a report to the physician to let them know their degree of retinopathy, usually in diabetic patients. That has been assigned a status indicator of S. You'll be paid separately for that, and the reimbursement is going to be $55 approximately there. All of my rates here are national before any wage adjustment is done, so that won't be your exact reimbursement, but it's national. A couple new codes that they've assigned reimbursement for: the implantable glucose sensor system. So this is what sits on your skin and can actually sense the amount of glucose. I just wanted to let you know there that those have changed. It's a significant reimbursement change, so I wanted everyone to be aware of that. Was $500, it's up to $1,700. So if you do that, there's a big win. Unfortunately, these are the procedures that not everybody does, but if you're thinking about doing them, the reimbursement has improved. This is for the nano knife. These are also fairly new codes, and you can see here that the reimbursement has close to doubled there from this current year. So that is also a good, nice one. And the percutaneous tibial nerve stimulation that's done to control incontinence, just amazes me that that works. Take a look at that one. For 2020, for the device insertion, we were at $652. We've gone up to $6,000. And we were at $262 for the revision or removal. We're now up to $32.75. So if you happen to do that procedure, that's a nice little boost in that area. They had that one way underpriced, apparently. All right, the tympanostomy with automated tubes. So that is inserting the tube into the eardrum. It's a new automated delivery system. That was not payable last year. They've now made that one payable up to for $1,300. Yay. And last but not least, we have the venous mechanical thrombectomy. So when you go into the vein, not the artery, and actually take out a thrombus, that's been reassigned, and the reimbursement for that has a little more than doubled for next year. All right, I put this slide in just because there was a very large discussion around this in the proposed rule and in the final rule about the status indicator for remote services. I'm sure I don't have to let anyone know that the use of remote services is way up this year as things have moved more off-site. Unfortunately, there was lots and lots of discussion, but CMS did not make any changes to the status indicator assignment. So the remote physiological monitoring, this code group up here, remains a status indicator B for the facility, meaning essentially that there is no OPPS reimbursement for that. The virtual check-ins are payable under a fee schedule methodology, so that hasn't changed. The telephone E&M services are also payable under alternate methodology, so that's good. The medication management is a status indicator B, that hasn't changed. So CMS did mention, though, that they are going to continue to look at these and see if it's appropriate to make these separately payable, but right now, not all of them are. All right, let's talk devices. We have a little bit of some good news here. CMS has made it a little bit easier for manufacturers to seek approval for pass-through status for devices. So we have more than we've had since a long, long time, about 2003 or something. Do we have more devices that have a pass-through status in 2021, which means they will receive separate reimbursement. These are the items that we have, the Surefire Spark, and I also gave you the CPT codes out here, the Optimizer system, the Aquabeam system, the Augment bone graft, the artificial iris, the Barostim Neo, and the Exalt single-use duodenoscope. These have been approved under a breakthrough device alternate pathway, so a little bit easier path to getting pass-through status. I'm just happy that they're finally recognizing some of these new technology things a little bit quicker and realizing that these do have quite a cost associated with them in some cases. Also, between the proposed rule and the final rule, they actually were convinced and added 2 new devices for pass-through status. They were on the fence about these in the proposed rule. Both of them did get approval for 2021, and pass-through device is going to start January. So the hemo spray is for a non-variceal GI bleeding. It's a powder with a unique delivery system. And the spine jack is a device that's used in association with bone cement for vertebral fracture. It's basically implants that are put in to help stabilize that bone cement. Those both have pass-through status beginning in January. A quick little refresher on the device-intensive procedures again, both because I get a lot of questions on this and because I'm assuming CMS does too, because they really hit this in the final rule too, to just remind everybody that they quit publishing the list of specific device to procedure edits and vice versa in 2016, 15, 16, I can't remember right now. So basically, if you have a device-intensive procedure, you have to have a corresponding device on the approved list, but CMS is not necessarily looking for it to make sense. So what I mean there is that pacemaker insertion, for example, is on my list of device intensive, but you don't necessarily have to put a pacemaker on the procedure for it to bypass the edit. You could put a defibrillator on there. You could put a guide wire on there. You could put a joint replacement device on there, and it will bypass the edit. So there were a lot of calls for CMS to reinstitute these, and their response was basically, we've given you enough time with this. You better know how to code correctly at this point and not be sending us the wrong stuff. So that was their response, and they are not going back to produce a specific device to procedure edit list. If you would like to see all of the device intensive procedures, of course, we have that information in Vital Knowledge, and your account manager could help you find that if you're not exactly sure how to do that. If you don't have VitalWare, all that information is found in Addendum P, which is attached to the final rule. All right, moving right along, let's talk drugs, my favorite topic. Again, just a quick little summary for you. We have 68 drugs and biologicals that are going to continue or that are new to the pass-through status for 2021. And that would mean they have a status indicator of G and that they are separately reimbursed regardless of their costs for at least 2 years, but not more than 3. Okay, so basically, long and short of it is you will get extra reimbursement for these pass-through drugs. Again, that is all available in Vital Knowledge or in Table 38 of the final rule if you want to know that full list of 68 drugs. I did want to give you ones that are expiring just so you can prepare if you need to. These are the drugs that are expiring pass-through status, and here's what's happening to them. So this first one is becoming packaged. The others will continue to get separate reimbursement under status indicator K, and here is that reimbursement for January. These reimbursement rates are, or can be, I should say, updated on a quarterly basis, but this is what we've got right now going into January. And of course, you'll get the presentation too. Don't worry about like madly scribbling codes down. You will have access to this after the presentation. All right, our packaging threshold is not changing. It's going to remain at $130. So again, a little bit of a bright spot there. And just a quick refresher that when I say this, that means that your drug will be separately paid if the usual customary dose price is at or above $130. If CMS deems that usual customary dose price to be less than $130, your drug is going to be packaged into other services provided on the claim. They've been bumping that up. We started at $50 way back, and we are now up to $130. but at least it didn't go up again this year. Now the bad news, good news, I guess. The non-pass-through drugs. So this applies only to drugs that don't have that pass-through status that we were talking about previously. And your drug is purchased under the 340B program, which would be drugs that you've assigned modifier JG to. Those are going to continue to be paid at the average sales price minus 22.5%. So normally our drugs, if they're separately reimbursed, they're paid at average sales price plus 6%. So this is essentially taking out 28.5% of your average sales price payment. And this started a couple of years ago, so this isn't new. CMS had been toying with actually reducing this further to be average sales price minus 28.7% for 2021. They were persuaded that that may be too much of a cut at this particular time, but warning, they did, I do expect them to come back and decrease this reimbursement in future years, because there was a lot of talk throughout the final rule about how they think ASP minus 28.7 is perfectly reasonable. So not at this particular time, but I do think it's coming. We did have a lawsuit over this. The AHA had sued CMS to stop this. They were unsuccessful. No, they were successful at first, and then it was overturned on appeal, and it has now been upheld by the DC Circuit Court. So I don't believe, I haven't seen yet if this is going to be appealed to the Supreme Court, but that would be the last stop. Otherwise, this is going to continue to stay. The modifier use is what's going to trigger your reduced payment. If you are one of the facilities that is not subject to this payment reduction, CMS would still like you to use a modifier, but it would be modifier TB that is essentially informational only. And if you use that modifier, there will not be a payment reduction. You should be using that TB modifier if you acquire drugs under the 340B program, but you're a sole community hospital or a children's hospital or one of the cancer hospitals that are exempt from the OPPS. I should have put Maryland hospitals in there as well, because they're exempt from the OPPS. Okay, again, this payment reduction is only going to apply to drugs that have a status indicator of K, which means they receive separate reimbursement, but they're not passed through. It will not apply to vaccines or the pass-through drugs, and it's not going to apply to any hospitals that are not paid under the OPPS. So the critical access, the Maryland hospitals, the other ones on the previous page. Note that they are also not changing the fact that this does apply to hospital outpatient departments if you're non-accepted. And we kind of already went over this. The DC District Court has sided with CMS. This is going to stick around. There's really nowhere else for this to go unless they're going to appeal to the Supreme Court. And I think they have until January 15th or something to do that. So I don't know yet whether or not they're going to try and appeal to the Supreme Court. All right, skin substitutes have been a topic since the beginning of skin substitutes. CMS is concerned that there's, and not just CMS, I believe hospitals are very concerned that there is a lot of variability from year to year in the reimbursement of skin substitute products. So they are requesting comment on these alternate methods of reimbursing for wound care. So if anybody has any strong feelings in that, make your voice heard to CMS. They're talking about potentially a lump sum payment for wounds treated, a single APC that's going to be somewhere in the price between low and high cost skin substitutes. Right now we have 2 APCs, depending on which type of skin substitute you use. They're also talking about maybe assigning one of those comprehensive APCs that could be adjusted for complexity for multiple wounds. And they're also talking about whether or not there should be a delay in implementation, depending on what they settle on for a methodology here. So I would expect that to come shortly as well. Wow, this stuff gets dry. So, sorry, guys. CMS changes are not the most thrilling subject here. They did change their definition of skin substitute products, and this is going to be pretty important. They are including synthetics now in the skin substitutes. So we have a new code that was effective. It is already effective. It was effective in July. It is for the synthetic skin substitutes. It's going to be assigned to a high-cost group right now. Notice that they updated their definitions here because I think they're finding that possibly some stuff is being incorrectly coded. So I thought this was really important that they put this clarifying statement in here that skin substitute products don't function like human skin. They're not a substitute for a skin graft. They're actually designed to integrate into the wound and to aid the wound healing, not just cover it, but to actually help with the healing process. And they wanted to be sure and let everybody know that that does not include any kind of bandages or standard wound dressings. So beware, they are looking at the coding of these more lately. All right, we're going to quickly go over the partial hospitalization. We have some good news here. This reimbursement has been decreasing year over year, and it's again because reported costs have been decreasing year over year, which doesn't make sense to anybody, including CMS. So if you happen to either have a PHP within your hospital or you are freestanding PHP, please, CMS is really encouraging you to take a look at your costs because it really doesn't make sense that the costs are decreasing. CMS is going to continue to monitor the use of partial hospitalizations. They continue to be a little bit concerned that people aren't receiving enough services. So they wanted to remind that if you have a partial hospitalization program, that technically includes services of at least 20 hours per week. So in order to hit that threshold, they don't expect to see a lot of claims that only have 3 services per day, because those essentially that's 1 service, 1 hour. Not quite that simple, but that's how they're counting it. So they would expect to see at least 4 or 5 services today. This is another thing they're continuing to monitor. So just a little heads up there if you happen to have partial hospitalization services. Now, probably what a lot of you have been hearing about, it's new for this year, sort of. At least the extension, how extensive it is new for this year. CMS did go ahead and finalize their proposal to phase out the inpatient only list. They're going to do this over a 3-year period, and it's going to start in January. So originally in the proposed rule, they were starting with the 266 musculoskeletal procedures essentially in the 2000 range. This was in the proposed rule. For the final rule, they're adding to that another 16 procedures that were recommended by their advisory panel. And they're also going to remove 18 anesthesia codes. Sorry, that should say codes, not code. That went along with the musculoskeletal or the panel recommended procedures. So all of those are coming off of the inpatient only list as of January 1st. There is going to continue to be a 2-year exemption on site of service claim denials, and they've actually expanded that slightly. So we'll talk about that. I found this super interesting. They have actually committed to issuing guidance on how to determine whether your procedure is being done in the appropriate site of service. They cautioned that that nobody's going to hold you to that. They don't want any reviewers to actually use that to deny claims, but they're just getting more and more requests for help as to, okay, if you're taking this off of the inpatient only, then how do I know whether that needs to be outpatient or inpatient? They're hearing that reviewers are coming along behind and they're saying, oh, this isn't on the inpatient only list anymore, and therefore you have to do it on the outpatient list. I counted no less than 20 times that CMS in the final rule said, it does not mean, just because we take it off of the inpatient only list, does not mean you have to do it in the outpatient setting. So I'm going to say that again, and I'm probably going to say it again because that is crucial. Just because it's not on the inpatient only list doesn't mean that it has to be outpatient. Right now, your doctors should be making that call, and CMS is going to issue some additional guidance to help you with whether it should be in or outpatient, guidance only. So kind of along that same lines, any procedure that has been newly removed from the inpatient only list is going to have an exemption period, which is kind of sort of indefinite. They called it indefinite, but it's not really indefinite. It's indefinite in the fact that they're going to continue to monitor where these services are being reported. And at such time as they are reported more on an outpatient basis than they are on an inpatient basis, that is when this exemption period is going to end. So that what that exemption means is that the RAC is not allowed to review procedures newly removed from the inpatient only list for site of service. They can't come along and say, okay, this has been removed from the inpatient only list, therefore you should have billed it outpatient. So this is an important exemption, right? It's no longer going to be up to the RAC to deny for the procedures that are newly removed from the inpatient only list. It's really important to understand, though, that the exemption applies to patient status only. It doesn't mean that the RAC can't review it for medical necessity, and it doesn't mean that your QIO can't review it for medical necessity or for education purposes. Okay. So I like this exemption. I like that they're doing this. They're giving hospitals a chance to get used to the fact that these inpatient-only procedures can now be done either outpatient or inpatient, depending on the medical condition of the patient and the physician's clinical judgment. I highlighted this, I shaded this. This was what was throughout the final rule. I just think this is crucial. This is a direct quote from the final rule. It is a misinterpretation of CMS payment policy for providers to create policies or guidelines that establish the outpatient setting as the baseline or default site of service for a procedure based on its removal from the inpatient only list or the elimination of the inpatient only list. So what I just said, do not assume that because these procedures are off of the inpatient only list that they have to be done outpatient. Please, if you take nothing else, take that, because that's going to be really important. All right, let's move over into our non-recurring policy changes. And I need to see if someone can maybe set me up with a Chardonnay drip here as we get through the end of the year. I think that would be incredibly helpful for me. Probably not allowed, but it would be nice some days. All right, we have a change in the supervision level, which could kind of fly under the radar, but I think it's pretty important. CMS has, what's the word I want here? CMS has issued a temporary change in the supervision level for these non-surgical extended duration therapeutic services. So things like chemotherapy infusion, radiation therapy, these previously had to be done under the physician's direction and control, at least to start them. We're now changing this permanently over to a general supervision requirement, which means that The procedure has to be furnished under the physician's overall direction and control, but the physician's presence is not directly required during the performance of the procedure. And kind of like I said with the last category there of the inpatient only, that doesn't mean that your hospital can't require a higher level of supervision, for example, in your bylaws. And it also means that you have to comply with local laws. So if you have local laws that require a higher level of supervision, this isn't going to supersede that. It just means that that CMS is relaxing a little bit the supervision level for some of those procedures. I left this one in here because this was in the proposed rule. It's not going through. There was a proposal to permanently allow direct supervision of rehab services, cardiac and pulmonary, using the interactive audio and visual telecommunications technology. This is another change that is in place right now during the public health emergency, and it's going to continue basically until the end of the public health emergency or the end of next year, but this will not be made permanent. They were talking about making it permanent. That's not happening. Our favorite topic here, they've called it method to control unnecessary increases in spending. Again, this is not new. I just wanted to make sure that everybody knew, because this was another lawsuit by the AHA in order to halt this, which basically what this is that any of your clinic visits done in your outpatient provider departments, whether or not you're accepted, you are getting reduced reimbursement. It's equal to 40% of the OPPS reimbursement, so that's $47.50 for 2021. That had been in lawsuits, in appeals. CMS won that one as well, so this is going to continue. If anybody out there was hoping that this was going to go back, it's not at the current time. We're still in the same spot there that they could appeal it to the Supreme Court. I don't believe they're going to. And then I just wanted to do a little update on the prior authorization that started in July 2020. We are adding a couple of new categories to the prior authorization process. We actually did a webinar on that one, I believe in late June. So if you want a little more detail on the prior authorization, that one should still be accessible out there if you want more detail. Basically, we're just adding two categories of cervical fusion with disc removal and implanted spinal neurostimulators. Here's the codes that are going to be subject to prior approval. CMS found greatly increased use in these procedures, and that is why they've added them to the list. Apparently, they forgot the fact that they asked for hospitals to be doing more of these procedures to help try and wean people off of opioid drugs for back pain. But at any rate, these are now on the prior authorization, so you will have to seek prior authorization for these services on or after July 2021, July 1st. These are the categories and services that were already on the prior authorization process. So again, I just wanted you to have that. I'm not going to read these to you. You should already be doing this, but there's a quick reminder if you need that. And another just quick reminder there that if you don't meet the pre-authorization requirements, the claim and any associated service is going to be denied. You can't appeal that decision, but you could resubmit more information. And you're supposed to receive a decision in 10 business days, or 2 if your request is expedited. Apparently, this is not happening quite so timely, but CMS is directing the MACs to kind of speed this up, basically. This is, again, just quick reminders that this process started in July. When you request pre-authorization, you get a unique tracking number that has to be included on all your claims. and they are monitoring for compliance. Your hospital could be exempted from having to do this if they find that you are compliant at least 90% of the time. All right, our last little topic here, and this one's actually going to be pretty quick. For those of you that I am so sorry have to deal with the outpatient quality reporting program, actually good news for you. Nothing's being added, nothing's being removed, basically no changes to this. They're continuing to hold on the survey for outpatient. So again, not going to read this to you, but just so you know, these are the measures that are in place for the 2023 payment determination, which if you remember, they collect data through 2021 and it impacts your reimbursement 2 years later. So that wasn't a typo, that should say 2023. A few more. And I also just wanted to make sure you had a nice little place to refer back because they've changed some of the submission deadlines. Okay, along with the quality, they've made a few changes to the star rating program, and people are becoming more and more aware of the star rating stuff. So this is the data that's published out there on the Hospital Compare website. It uses all of these quality measures, and I know we're acronym crazy there, but this is the readmission reductions program. So making sure that your patients aren't being readmitted at too high of a rate. That's the hospital acquired condition. You know, patient comes in without an infection, develops an infection during your hospital stay. Those are the kinds of things that go out there. And your value-based purchasing program. This is a little bit of a change. The star ratings are going to be updated once a year, but CMS is now randomly picking, I'm sure it's not random, but they're not going to tell us, a quarter in the previous year on which to base the update. So they could be looking at January, April, July, or October data in order to update this. Veterans Administration hospitals are now going to be allowed to participate in the program. They're not providing us too many details right now, but that is going to probably shake things up a little bit just because you're competing against all other hospitals for these stars. So it's a real fun little program there. They're changing the way they're calculating, and unless you're a math major, you're not going to care about this, but it is a fairly significant change of now that it's simple averages as opposed to their calculus formulations before that nobody could follow. They had a proposal out there to actually section hospitals off based on the percentage of dual eligible patients, so those Medicare and Medicaid patients that were being served. They've backed off of that, so that's no longer part of it. But they are actually grouping similar hospitals together based on the number of measures they submit. So that's simply designed to not pit small little rural hospitals who don't do much against big urban hospitals who do a bunch. They're hoping that that will be a little bit fairer way to assign the star ratings. So that is actually a fairly significant change. Keep an eye on your star ratings for next year. I would expect some shifts. And again, I'm not going to read this through to you. It will be select people who will care, but they did finalize a change in what they're actually looking at for the star ratings. So there's 5 measures. These 4 are weighted equally. This one gets a little bit less of it. If you want a lot more details, it's all available out there. But basically, this is what they're looking at for each of the groups. We've got, you know, a mortality rate, a safety rating, which is where your infections are going to fall, number of readmissions that you have, the patient experience, so that's the survey that goes out to your inpatients, and then timely and effective care is, it's actually now been put into one group, and that is all done via data that CMS is collecting without your knowledge. This part of it is from your claims data. And that was a fun little stopping place there. That is what we've got for 2021. So I will turn it back over to you, Dusty, for any
All right.
questions.
Yeah, we absolutely do. Thanks, Jen. I learned that drugs are your favorite topic, and
Yes.
forgot pretty much everything else. So it was
And I want a
successful.
Chardonnay drip. Don't forget
And,
that.
oh yes, and you want to turn drip.
If you can make that happen for me, I'd be really grateful.
We did have some comment about that, so might be coming your way. We'll see. Okay, I did put something in the chat really quick for everybody. If you want to look there about your CEUs, the presentation, everything else, best way to stay up to date with us is to either sign up with our web for our newsletter at the footer of our website on any page, and or follow us on LinkedIn. We try to keep everybody up to date there really well, or bookmark our webinar page, or do all three, whatever floats your boat. All right, not enough time, so let's get into some questions. I've got a couple on this, Jen. What are the HCPCS codes for hemospray and spine jack devices, if there are any?
That is a good question. And at the time that the final rule was put out, we didn't have the final HCPCS code file. So I will get those added into there and get that out before. Maybe I can send you a corrected copy there, Dusty, to get those out.
Yep.
So that it's in the presentation.
Yep, for sure. Okay. Next question. Is the JG modifier required for non-Medicare payers? How about managed Medicare?
That is usually a specific payer question. The Medicare Advantage payers that I have heard for the most part are requiring it because they base all of their reimbursement on Medicare. So I would say more often than not, yes. Whether other payers are requiring it, that unfortunately is going to be a payer-to-payer decision.
All right. What is or are the status indicator or indicators for the procedures that used to be inpatient only? SI equals C?
Yeah. That is going to depend on the procedure. Most of them that I saw, like way lion's share, it's going to be a J1, which is those comprehensive APCs, because by nature, if it was an inpatient only, it's a pretty complicated procedure that tends to be the only thing done on a given or during a given encounter.
Okay. Wouldn't we use modifier CG for device intensive procedures where no devices are used?
Yes, that will override a select group, not all of them, but that will override a select group of device intensive procedures. If you don't have a given device that you're using, that's why CMS created the HCPCS code of C1889, which is a device that's used, but it's not specific to a particular device. So if you have a device that doesn't have a code, that C1889 is a great one. If you are doing what CMS considers to be a device intensive procedure and you're just not using any device, that's when that CG modifier would come in. But again, that's not every device intensive procedure that can use that to override the edit.
All right, a couple more. How soon after inpatient admission can patient be brought back for outpatient procedure and have procedure paid separately?
There's not a specific, there's an other direction, outpatient to inpatient rule. I'm not sure if that question's specifically asking about so that it wouldn't maybe hit your hospital readmissions or be counted against you for the quality. And that depends upon exactly what you're doing. But other than that, you're not really going to hit against a rule that says, oh, we were just discharged for, I don't know, congestive heart failure stay on Tuesday, and we want to bring them back on Thursday to implant a device that's going to help control that. There's not really a specific date range for that.
We had a comment. Can you flip back to the supervision slide relative to cardiac rehab while we answer some questions? One person wanted to see that again.
Sure. It's way back there. There we go.
All right, couple more, then we got a hard stop here. Can you provide an update on site neutrality? Excuse me.
On site neutrality?
Yes.
Uh,
And then there's a follow-up. Another person asked with respect to payment reductions or changes related to PLPN modifiers. I hope that clarifies it all.
yeah, that helps me a little bit. That is definitely not new. That's been in place for quite a while. And I always get my modifiers mixed up, but one is accepted and one is non-accepted. Let me back up to this one because that will help me with which one is which. And I don't know if we're talking in particular with regards to the public health emergency and the fact that you can perform services, you can register patients' homes as an off-site department of the hospital. I'm not sure if that's what we're in particular talking about. There's no change to that. You can register patients as outpatient departments of the hospital. They can be accepted outpatient departments if you submit the information to CMS that you are registering the patient that way, in which case you're going to be paid the same as if the patient came into your hospital to have those services performed. If you don't want to go to that level or trouble or whatever we want to call it, you can still provide the services to the patient in their home, but you're going to use the modifier that says that it is a non-accepted service. And in that case, you're going to be paid the reduced reimbursement as though it's a non-accepted outpatient department of the hospital. And we have we've done several webinars that would deal with that under the COVID umbrella. Some of those are still out, and I believe we're planning to do another one in January to update everything. But I think that's what we're dealing with there. If not, please feel free to clarify that question, and we'll make sure that it gets answered in the document that goes out.
All right, it has to be the last question / topic. I'll read two of these together because they're related, Jen, but is CMS allowing a grace period for code changes since they were late in releasing the HIPAA codes and OPPS final rule? And is there any indication of waivers extending past calendar year for public health emergency for site of service, telehealth, etc.?
No grace period. CMS gets to be late with everything. You do not. So no, code changes, everything still has to be done by January 1st. And this is the only thing at this particular point that they are totally extending permanently, regardless of how long this public health emergency lasts, is the ability to have general supervision. They continue to say that they will, all of the other exceptions that are in place for the public health emergency, those have to continually be renewed by the secretary. Right now it's Alexander Azar. It's been renewed again. They have to continue to renew that. And as long as they do that, all of the exceptions, hospitals without walls and all of the other stuff will continue in place, but it's not permanent in any way. So.
All right, great. That's gonna have to do it. We are going through the E&M changes in detail on Thursday. That should be on our webinar website as well if you want to register for that, if you haven't already. Hopefully we'll see you then. Otherwise, really appreciate you joining us today, and we will talk to you all soon. Have a great day.
Thank you.